and she will present on immunotherapy in CRC.
All right. Well, thank you so much to Sarah and the Total Health team for inviting me and for putting on this great conference, especially here in Nashville, where I can roll out of bed and be here in about 10 minutes. So this is great. I am going to move ahead here. There we go. So I am a GI medical oncologist at Vanderbilt and have been there for several years now. Actually did my training there as well. So love Nashville, and it's good to be here with you. So I've been tasked to talk about immunotherapy and colorectal cancer. As you might expect, I'm going to focus most of my comments on the MSI-high data, but we'll talk kind of some of the older data in the metastatic setting, some of the longer term updates, as well as the recent data in localized disease, which I think is really exciting. We've heard a little bit from Dr. Smith and others yesterday, but there are some other emerging data that I think are really interesting and provocative. And then we'll talk about some future challenges as we think about how we can expand the use of immunotherapy in colorectal cancer. So as we know, microsatellite instability and mismatch repair deficiency, which for the purposes of this talk I'll sort of use interchangeably, is an incredibly useful prognostic and predictive biomarker, not only in colorectal cancer, but in really all tumor types. And interestingly, we saw the initial response signal in phase 1 studies of all comers where the MSI-high feature was really the predictive biomarker of response in colon cancer. So as we know, the PD-1 receptor, the ligand binds to the receptor, and pembrolizumab, as well as all the other anti-PD-1s, will basically prevent that ligand binding. We see other features histologically. We see a lot more T-cell infiltration in the MSI-high tumors. We see really high tumor mutational burdens in our NGS reports in these tumors. And all of those are really important and kind of useful in determining that this is an important predictive biomarker. So the very earliest studies looked at pembrolizumab, at that time MK-3475, before we even had a name, and basically looked at the difference between the mismatch repair deficient and proficient. You'll see the proficient or MSS patients really didn't respond either biochemically or radiographically, whereas the MSI-high, not only colorectal, but non-colorectal too, these were in patients who had highly refractory disease, and we saw initial response rates of 40% with extremely high disease control rates. And then when it was expanded, the study was expanded to other tumor types, we saw that this really was useful across the board, though we do see some differences in resistance outside the colorectal setting. So Checkmate 142 is one of the early studies looking at Nivo plus or minus the anti-CTLA-4 antibody ipilimumab, and we now have 5-year follow-up on this data, which really shows kind of the long-term effects and durability of immune checkpoint inhibitors in MSI-high colorectal cancer. So as a reminder, this was a non-randomized phase 2 study. So we currently have a phase 3 randomized study that's ongoing that hopefully will be able to look at this head-to-head in terms of the monotherapy versus the doublet. But for right now, we just have to extrapolate from the non-randomized phase 2, in which patients were either treated with Nivo or Nivo and Ipi, and these were in different lines. So some were front line, some were second line and beyond. What we saw here in the Nivo second line and beyond cohort, response rates again about 40%, very similar to the Pembro data, cross-trial comparisons aside. And then the cohorts 2 and 3 were the combination. One was in the second line and beyond, and one was front line. And you'll see really impressive response rates of 70% with Nivo-Ipi in the first line, which really was exciting. PFS, also you see that the cohorts 2 and 3, the Nivo-Ipi combination, a really nice flattening of the curve at a very high percentage of patients treated with these agents. So not only good response rates, but I think what's most important to us in our patients is this durability of response. Overall survival has not yet been reached in those 2 cohorts of the doublet, despite the 5-year follow-up, which is exciting. And then Keynote 177 was the randomized phase 3 study of pembrolizumab compared to investigator choice chemotherapy. And this was in patients who had previously not received any treatment. There was crossover to immunotherapy for the patients initially randomized to chemotherapy, and I'll explain why that's important. But dual primary endpoints here were PFS by central review and overall survival. So what we saw here, again, was in the pembrolizumab arm, we saw the really nice separation of the curves and flattening of the curves as you got further out. But I will mention that there was the initial crossover of the curves, that not everyone responds to immunotherapy, even in MSI high disease. That's a really important point and something we need to investigate further. When you look at the best anti-tumor response, I think this is really instructive as well. You had more patients achieving complete responses, even though sometimes we see radiographic discordance. But you see more patients with stable disease with chemotherapy. Of course, chemotherapy doesn't have the durability of response as immunotherapy does, but it's, I think, important to look at those differences. And as I mentioned earlier, duration of response is really something we value, particularly in patients who are able to go off therapy and maintain that response. The PFS2 was the time from randomization to progression on next line of therapy. So if you had immunotherapy and then progressed, which some patients did, they went on to chemotherapy. On the other arm, they often went on to immunotherapy. There's a high rate of crossover. It's about 60% in this trial. And that was why ultimately we didn't see an overall survival benefit for pembrolizumab. It was not statistically significant, even though the curves looked different. And that's important because, again, about the crossover, we don't think that there's any less benefit to pembrolizumab or really any of the immune checkpoint inhibitors in the first line, just because that overall survival benchmark was not hit. As we know, immunotherapy from the majority of patients is better tolerated than chemotherapy, though there are specific immune-related adverse events that are important to keep in mind. So not only I've kind of reviewed the data in pembrolizumab and nivo and ipi, but really all of the anti-PD-1s and anti-CTLA-4 combinations are really pretty similar, and in the metastatic setting are very useful. I would argue now that you need to test for MSI or MMR in every colorectal cancer patient, not only in the metastatic setting, but I'll show you data in which it's important for everybody. We see excellent durable responses with anti-PD-1, and then the addition of the anti-CTLA-4 antibodies in MSI high disease. There are still some questions about the use of monotherapy or doublet, and specifically, looking at the non-randomized studies, we tend to see numerically higher response rates with the doublet, but we also see more toxicity. So it'll be important to see results from Checkmate 8HW and others that are looking at the randomization of doublet versus monotherapy. I think an important thing to remember is that not all MSI high patients will respond, even in colon cancer, but also in other tumor types as well. So we really need to understand that better and figure out a way to make immunotherapy useful in those patients. Some patients will develop acquired resistance after initial response, so that's a problem as well. Of course, the larger problem, which I'm not going to spend a lot of time on today, is what to do in microsatellite stable metastatic colorectal cancer, which is the vast majority of our patients. I would say that there is one subset of patients who are microsatellite stable that do respond to immunotherapy, and it's the POL-E mutation carriers. So that's important to look at in your NGS reports. And then the FDA has approved in a tumor agnostic fashion use of immunotherapy for the patients with tumor mutational burdens 10 or greater. I don't think that that's really very useful data in the colorectal setting. I haven't seen much, and we really don't have data in that tumor type that's a very helpful regimen. Okay, so now that we've reviewed the data in the metastatic setting, we're going to look at the localized setting, and I want to highlight 3 studies that we have data on now that will hopefully convince you that we need MSI results prior to initiating therapy and how we're going to use that information moving forward. So this is the dostarlimab data from Memorial that Dr. Smith talked about yesterday a little bit as well. We were all very amazed at ASCO and even ASCO GI of last year, seeing the initial responses and clinical complete response. But as we know, most locally advanced rectal cancer patients are treated now with TNT, total neoadjuvant therapy, which includes chemotherapy, chemo and radiation, and ultimately total mesorectal excision. So this study was a single institution study, again done at Memorial Sloan Kettering, in which these patients who are MSI high, relatively small subset, but an important one, they were treated with dostarlimab, so the anti-PD-1 dostarlimab, and then their disease was reassessed after 6 months of therapy. And then if they had residual disease, they were planned for further standard therapy with chemoradiation and surgery if needed. And if they had a clinical complete response, they could go on to non-operative management. So the primary objectives here were response rate of PD-1 blockade with or without chemoradiation, and then path CR and complete clinical response after 12 months of PD-1 blockade with or without chemoradiation, also looking at safety. So just to mention, the definition of clinical complete response is very specific. So both endoscopically, you have to see visual disappearance of the rectal primary, a normal DRE, and then on MRI, a lack of signal, potentially with scar and resolution of the lymph nodes. So just to show you that these were not early stage tumors, but really we saw T3 and T4 were the vast majority of patients, and almost all patients had node positivity. So these were very high risk rectal tumors. Interestingly, you'll see down here that almost 60% of patients did have germline mismatch repair mutations, and 100% were BRAF V600E wild type, indicating that probably these were not as many sporadic MSI high tumors as we might expect in a different population. But of course, the really astounding data was that the overall complete clinical response rate was 100% in the first 14 consecutively treated patients. So that was something we hadn't really not seen before and is really exciting. I will point out that the follow-up at the time of presentation was still relatively short, with only a few patients approaching 2 years of follow-up. We now know that I think up to 30 patients have now been treated, completed the 6 months, and we have not seen any relapse in those patients thus far. So here you see the duration of response, and I'll point out here that again, at the time of presentation, the median follow-up was only 7 months. Most of the patients did hit that clinical complete response endpoint at 6 months of therapy, though there were a few that hit that endpoint early at 3 months of treatment, kind of raising the question, do we really need 6 months? What's the optimal amount of therapy for these patients now that we know it works so well? So again, I'm going to continue to reiterate that it's imperative to test for MSI and mismatch repair deficiency in all patients. In this section, locally advanced rectal cancer patients, but really in every colorectal cancer patient. We saw that PD-1 blockade alone induced a clinical complete response in all patients, these small numbers, of course. We're still not sure about generalizability. So as I mentioned, no patients had BRAF mutations, and there was a high rate of germline mismatch repair mutations in these patients. We don't know the optimal duration. We don't know if the addition of anti-CTLA-4 antibody would be helpful in some patients. And ultimately, this is a pretty small sample size with plans to expand in the near future globally and in a multi-institutional fashion. So I think it's really key that we complete enrollment on this study and others, because we really need the long-term follow-up. We need to establish the generalizability of this approach, but it's very exciting. So kind of switching gears to the colon cancer space, we've seen very recent data from Miriam Chalabi and her group in the Netherlands of colon cancer, patients with localized colon cancer being treated with upfront neoadjuvant nivo and ipi for a very short course prior to going to surgery. So the niche One data, which was a small sample size, looked really incredible with this waterfall plot that we never see in terms of response to small amounts of combined checkpoint blockade. So that led to the Niche 2 study, which was presented at ESMO last year. And again, how the schema was that patients were treated with 1 dose of Nivo and Ipi, got a second dose of Nivo, and then went straight on to surgery. So really didn't delay surgical resection very much at all. The objectives here were, of course, to make sure that this was safe and feasible and that it didn't preclude surgical resection, which was considered curative prior to this, and then 3-year disease-free survival. And there are a number of correlatives ongoing that we'll be hearing about in the next couple of years. So in this study, we also saw that these were very locally advanced patients. So high-risk stage 3, 3/4 of patients fit into that category. It was a little bit more of maybe a real-world population. Only about 1/3 of patients had Lynch syndrome. But you see that in the T4 and N2 patients, these were the majority of the patients treated here. I will mention that there can be some radiographic discordance with MSI high disease, where these patients can seem really locally advanced, and when you actually they go to surgical resection, sometimes they're not as advanced as they appear on staging, but these are certainly clinically considered to be high risk. So a couple of definitions to be able to understand the endpoints here. We saw, or they defined pathologic response as 50% or less viable tumor in the surgical specimen. Major pathologic response was 10% or less, and then pathologic complete response was clearance of the tumor in both the primary tumor bed as well as the lymph nodes. So again, this is kind of colloquially called the Chalabi plot now. So seeing this incredible waterfall plot that we wish we could see in every tumor type with every treatment. But major pathologic response, so again, 10% or less residual viable tumor, was seen in 95% of patients. I want to remind you, this was only after 2 doses of Nivo and 1 dose of Ipi. And they saw a 67% path CR rate in those patients with short-term neoadjuvant immunotherapy. There were a couple of patients who went on to get adjuvant chemotherapy. A median follow-up is still fairly short, just over a year, and there have been no disease recurrences thus far. This figure on the bottom is kind of the conglomeration of the Niche 1 and Niche 2 patients, and really putting them together really kind of confirms this nice neoadjuvant approach for colon cancer. Kind of makes us think, okay, is surgery even necessary? Which is probably the next question we'll need to answer. So in Niche 2, the path CR rate in Lynch versus sporadic tumors did look a bit different, so at least numerically. So patients who had Lynch syndrome were much higher, much more likely to have a path CR, whereas those with sporadic tumors, it was not quite so different. So I think some conclusions from Niche 2. So again, the localized colon cancer setting with in MSI high disease using immunotherapy. I didn't show you the adverse events, but they were really very tolerable, as you might expect with such a short course of immune checkpoint inhibition. There was 4% grade 3 or 4 immune-related events. All patients essentially underwent R0 resections and in a timely fashion, so the safety endpoint was met. And then 100% had response, with 69% path CRs and 95% of that major pathologic response. So again, can we do non-operative management? I think that's the next question. It's a little bit of a harder question to answer than in rectal cancer because the risks and morbidity from surgery is different. If you think about, say, a laparoscopic right hemicolectomy versus an APR, these are different experiences for patients. Additionally, it's a lot easier, at least as a non-GI or surgeon, to do flex-sig surveillance than full colonoscopy to maintain this, especially in light of radiographic discordance, where sometimes we see tumor and it's not actually there, it's just scar. So stay tuned. I think this is going to be a really important avenue of exploration in the next few years, and there are many studies being designed and currently being undertaken to look at this even further. And finally, in the localized MSI high setting, I did want to bring up the MD Anderson experience, which was recently published in the JCO and previously presented at ESMO in 2021. So this was a small group of patients with what was deemed high-risk, locally advanced MSI high tumors. So most patients were colon or rectal, but they did include other GI cancers and non-GI cancers as well, as I'll show you. And patients were given neoadjuvant pembro ×2. And then if they were deemed to have a clinical benefit as defined down here, then they could go on to additional pembrolizumab and then either go to surgery or continue pembrolizumab therapy. This was not randomized, but really was per patient and physician preference. So primary endpoints here were path-CR of the patients who did go on to surgery, as well as safety, and then secondary endpoints, response rate overall, not only in the resected patients, but in the unresected patients as well. So here you see kind of the contour diagram of the patients who actually were on this study. So you'll see about half went on to surgical resection and half went on to ongoing pembrolizumab, generally for up to a year, though there was variability there as well. And what you see over here is the demographics of these patients, and I'll highlight that again, about half of the patients had colon cancers, about a quarter had rectal, but there were others in the GI group, but also endometrial and other non-GI cancers as well. It was about half and half of sporadic versus Lynch syndrome, so again, important to include both of those types of patients. So what did we see in this study? We saw that in the patients who underwent surgical resection, neoadjuvant pembrolizumab did yield high rates of path-CR, so kind of similar to the NICHE-2 data, but this was not only colon. And you can see here kind of where I think my pointer left, but you can see in the second column on the right that the patients were pretty locally advanced, again, considered high risk, and then had very nice responses to the initial pembrolizumab. And then overall, in both the resected and unresected patients, response rates were extremely high, 75% overall in over 30 patients. And we really didn't see any difference by subtypes and clinical features in terms of those who responded more than others. Thus far, there have been low rates of progression on neoadjuvant pembrolizumab, so that's an important point too, especially for some patients who might undergo colonic resection, which is, relatively straightforward. We want to make sure that we're not harming patients by avoiding that standard of care therapy. And this is just one of the figures from their paper, also showing in the bottom right the correlation between response and variant allele frequency too. So a lot of important data here, and I'll point you to that article as well as our accompanying editorial. And so conclusions from this study, from the MD Anderson experience, very high, again, path-CR rates, 69% in patients who underwent resection, the relatively small sample size, high response rates, higher than what we traditionally see in the metastatic setting, though obviously cross-trial comparisons again. As I mentioned earlier, surveillance can be a little bit more difficult in the non-rectal population, which has potential implications for non-operative management. And then, of course, this question, why are we seeing such amazing responses in these earlier stage diseases as opposed to the metastatic stage? And that could be because there's more T-cell infiltration earlier in the disease process. There's less systemic immunosuppression, so perhaps these immune checkpoint blockade inhibitors can work better. And finally, just in the last minute or two, I just want to highlight a couple of studies that are being done in this field. There are many others that are being designed and implemented. So this is our ECOG Akron 2201 study, which has been ongoing for about a year and a half now, looking at neoadjuvant Nivo and Ipi with short course radiation in the locally advanced MSI-high rectal cancer population. So the top line there is the current schema, which is where we opened a year and a half ago prior to the dostarlimab data being available. And so patients received 2 monthly cycles of Nivo-Ipi, followed by short course radiation, and then 2 additional cycles followed by disease reassessment and, if needed, TME. The primary endpoint is PathCR, and I can tell you that when we designed this study, we hypothesized that a PathCR rate of 50% would be reasonable with this treatment, and people thought we were crazy. But now I think you can see that that perhaps was not ambitious enough. But now we are currently in the process of amending the schema so that patients will get all immunotherapy up front for monthly cycles of Nivo and Ipi, followed by disease reassessment. If they achieve a clinical complete response at that point, they can go on to non-operative management. So this study is open in about 80 sites across the country and geographically kind of widespread. So look for that for patients who might be eligible. And then NeoPrism CRC is being run by Kai-Keen Xu, our UK counterpart. He's actually looking at neoadjuvant pembrolizumab stratified by tumor mutational burden, and they're doing a host of correlatives, which I think will be really, really important and useful to kind of evaluate how best to use immune checkpoint blockade in the earlier stage colon setting. So this is an ongoing study as well in the UK. And finally, I think my overall conclusions here, when I think about immunotherapy and CRC, immunotherapy is promising in all stages for MSI-high disease. We do need to figure out how to get it to work in microsatellite stable disease, and there are a lot of efforts being undertaken there. I hope you take away from my talk that it's imperative to test for MSI-high or mismatch repair deficiency at every stage. It should be reflexively tested, in my opinion, in colorectal cancer. Immunotherapy has the potential to spare patients from other modalities of therapy, surgery, radiation, I should have put chemo in there too, as well as cure disease. So it's really an important thing to consider. I think we'll need the ongoing biomarker studies to better understand how people respond or don't respond. We don't yet know what the optimal duration of immunotherapy is. ctDNA may be helpful here. And then finally, please enroll your eligible patients on the ongoing prospective studies so we can learn more as we move forward. And with that, I will finish. Thank you so much.
Thank you. I do have two virtual questions. One is IHC for MMR enough testing for CRC patients, or should all patients also be getting MSI by PCR? Yes,
this is a great question. So I generally think one or the other is sufficient. And generally at our institution, we tend to do MMR testing by IHC more often, though either is fine. We tend to also send NGS, so we try to get the MMR status early, so that at our institution it's done reflexively, so I often already have that information when I see patients initially. And then we get NGS. There are some additional things that can be helpful. So tumor mutational burden, if you see it's 100 mutations per megabase, or you have that POLE mutation, so there are additional things that might make you want to utilize immunotherapy. But in general, I think MMR testing is fine. There's a slight rate of variability or discordance between the two. So if you're really suspecting that this may be a patient who might be MSI high and your initial mismatch repair testing is negative, it would certainly be reasonable to confirm with the other test.
Great talk. I hope everybody understands the tour de force that you just gave everybody on immunotherapy. So two questions. One is, can you enlighten everybody on so I think your trial design is important, as we've discussed, in terms of using radiotherapy I think there's some rationale there that you didn't get into, but maybe you can just talk about that in terms of maybe enhancing your response. In terms of, because I do think, and I was one of those people that thought maybe your PCR rate of 50% was too low.
Thank you.
Maybe we had some data that suggested that as you were designing your study, but maybe you can talk about that a little bit. And then also, if we're talking about non-operative management in the colon cancer setting, can you talk a little bit about distribution of right versus left? Because I think that would be important in terms of if we were going to offer a non-operative managed approach there. Because it's certainly different to do a scope on the right side versus the left side.
Absolutely. And I'll take that question first. So I think there are nuances here. So clearly, I always use the sort of discordant, the right hemicolectomy, which can often be done laparoscopically and very easily, versus the perhaps more locally advanced sigmoid tumor, which is much easier to surveil. So I think that's a great point, and there may be a spectrum, really, in terms of who can undergo safely and effectively non-operative management. So I think we'll have to tease out those questions. Of course, MSI tends to happen more often on the right side, and so that may play into that as well. And then your first question about the ECOG study, it's a great question. So we initially designed the study, and we went back and forth a lot in terms of we knew we wanted a certain amount of immunotherapy, and we actually chose short course radiation because there's some preclinical data that it could perhaps increase immunogenicity, and then that was why we kind of put it in the middle, sandwiched in the middle of the immunotherapy, so hopefully enhance the response of the immunotherapy to the tumor. But after the dostarlimab data came out, then we heard a lot of feedback from treating physicians, from patient advocates, and patients themselves that they didn't want to have to even do short course radiation if they didn't need to. So as sort of a compromise there, we did move it after the 4 months of nivo and ipi, just so that we can see if patients do need additional therapy, they can still go on and get that. And the timing, it'll still be relatively close to when the immunotherapy is given. So we hope that immunogenicity, if real, is enhanced. I think that was all I wanted to say about that. I felt like I had another point, but I'll come back to it if I think of it. Thanks for those questions.
Thank you. I'll do one more virtual question. Any data or experience treating resected stage 3 colon cancer MSI high patients with adjuvant immunotherapy versus standard chemotherapy?
Yes, so not yet, but we do anticipate some adjuvant data coming through the cooperative groups. Question is not ideal. It's FOLFOX plus or minus atezolizumab in the resected stage 3 MSI high patients, but I think it will give us some data that will be important to kind of move forward. But yes, that is clearly the question. And something we deal with in the clinic all the time in terms of, okay, you have a stage 3 patient, MSI high, do you give them adjuvant chemo? We don't have any data or approval to give anti-PD-1 in that setting yet, but definitely a question that needs to be answered.
Thank you. Two more questions?
MSH1 PMS2, one or both respond as well to immune therapy?
Yeah, it's a great question. So we think so. So we haven't seen in the sort of post hoc analyses of many of these trials, we have not seen a difference according to mutational status. Again, I think the biggest difference between BRAF mutant and wild type is whether they're Lynch or sporadic, and so we might see some differences there. But in the setting of true BRAF mutations, we don't see that patients have a poorer outcome to immune checkpoint blockade. In the metastatic setting, I get this question a lot in terms of which do you target first? Do you target, with immunotherapy or with the beacon regimen? I generally say mostly on the basis of the potential durable response with immunotherapy. I use that first, but it's great to have a backup in terms of being able to target BRAF as well in those patients if needed.
I actually have like a two-part question. So one is, are there strategies to make like these immunologically cold tumors hot? I mean, is that where maybe additional research is going?
Yeah.
And then two, I think we all talk about the short-term data with these strategies, but if you're having Lynch syndrome, you're at risk for multiple tumor types. You see this kind of cycle of like stop and start with immunotherapy, as being probably the future of that.
Yeah, great question. So that the last question. So I do think this is we're just getting into this where we're seeing the initial results of immunotherapy looking really great in multiple stages of disease, but we don't really know how to utilize it in the proper form. And what we know from the metastatic setting is that we give up to potentially 2 years of checkpoint blockade. Some patients clearly don't need that much. And probably most patients don't need more than that. But again, we haven't answered even that question in the metastatic setting. So I think it'll be even more important with these really high response rates we're seeing in the earlier stages, that that may be an even more important thing to consider, especially given that there are some toxicities from immunotherapy that can be lifelong. So important not to expose our patients to too much toxicity. And then the first question, I forgot. Oh, the immuno, yeah. Yeah, so that is, I think, the hottest topic and the most needed area of development for immunotherapy in colorectal cancer, is those in the MSS non-poly patients. Everybody clearly wants immunotherapy, and it just hasn't panned out, because again, you don't have these high tumor mutational burdens, all these neoantigens for the checkpoint blockade to work with. And so there are lots of things that have been investigated and are currently being investigated. So things like TKIs plus checkpoint blockade, so Rego-Nivo, many studies looking at LAG-3 in combination, anti-TIGIT, other things too, vaccines, other chemotherapies that may enhance the immunogenicity. So not a strong signal across the board yet. We do see some potential signals in subsets that may be important, but that's definitely an area of exploration.
Thank you. Great
Thanks.
discussion. Next up, I'm going to invite Dr. Mohammed Salam to the podium, and he will present on colon, rectal,